Please welcome telehealth and technology reporter for Inside Health Policy, Cara Smith, and CEO of Access TeleCare, Dr. Chris Gallagher.
Hello, everyone. My name is Cara Smith. I'm the telehealth and health technology policy reporter with Inside Health Policy. For those of you who aren't familiar with us, we're a DC-based news outlet for policy professionals, and I am very excited to be facilitating a conversation with Chris Gallagher, who's the CEO of Access TeleCare. But was also a practicing physician at one point. So Chris, do you want to, introduce yourself and talk a little bit about Access TeleCare?
Sure, thanks, Cara. Really excited to be here to talk about my favorite topic, telemedicine. So I started out as a cardiologist and then worked my way into the telemedicine space through clinical practice. And so it's been a really interesting journey. It's been over a decade, and it's been amazing to watch the industry transform and really get through the last few years, as COVID's been an amazing catalyst for virtual care.
Mm-hmm. Great. So I think my first question for you is, I know you have experience working in rural hospitals. And that experience kind of led you to found your first company, which is Access Physicians. And I was wondering if you could give us a little bit of an insight to what specialty services, do most rural hospitals demand in terms of what they don't have themselves.
Sure. So starting a career as a cardiologist, that's a really common specialty that we see needs for. Kind of thinking about telemedicine, its role in rural healthcare, I think is kind of the story of how to get there. And myself, I really found myself and my colleagues 10 plus years ago working with our clinical partners, delivering very traditional types of care. And that care was hyper specialized. And was really limited to urban environments where we had the tools, the needs, the people to deliver those, cutting edge types of models of care. And so as we think about rural spaces, and as we worked to get into those rural spaces, the types of care that they need are very diverse. They need the same types of care that we would deliver in urban environments. And so as we walk through those hospitals, we would see need for cardiology, pulmonary critical care, infectious disease, behavioral health, et cetera. So really kind of core service lines that we've delivered at those smaller facilities.
Okay, great. I think my follow-up question to that is, what challenges have you experienced in terms of setting up telehealth infrastructure in rural hospitals?
So if you asked me that question maybe 10 years ago, we would have talked about broadband internet speeds. Mm-hmm. As we've kind of evolved over the last decade, not only have we seen speeds improve, but really the change management. A lot of resistance to virtual care a decade or so ago. We've seen people be more accepting of that, so the change management in terms of models of care is less of an impediment. We do still see challenges in regards to the infrastructure within the hospitals themselves, so access points, Wi-Fi coverage, just the specialty or the IT support staff within the hospitals themselves is limited. The technology always, Murphy's Law is always at play. And I think we saw that with the last video, right? It lets you down when you need it sometimes. And so redundancy has really been a key to telemedicine. We feel that. And part of that is having redundancy around the network connectivity. And cellular backup has been really important to assure that care can happen and can always happen, especially when the network goes down, whether it's Wi-Fi or Ethernet. And so that's been a challenge still in rural communities, is having access to high quality cellular connectivity.
Okay, that makes sense. It's very interesting to see how things have evolved just over the past 10 years. I think my next question for you is about something I've heard multiple times today and before that everyone is talking about in terms of the DEA's proposed rule that would re-implement in-person requirements for the prescription of controlled substances via telehealth. I know Access TeleCare works with providers on the ground, so it might not necessarily impact you guys like it would some strictly telehealth companies. But I was wondering if you could tell me, especially with your experience as a practicing physician, whether you think that in-person requirements are safer for patients.
It's definitely a controversial topic. And it's one, so in terms of the prescription of controlled substances, our work experience across our 2,500 programs in all 50 states is predominantly with patients who are inside of hospitals or other facilities. So we do have in-person peers that are there, and so it's very different. And so kind of like our data points around this are probably less than maybe others have. But with regard to controlled substances, I think it's something that, twofold. One, we are in a time where we have an epidemic of controlled substance abuse, and I think we really need to take that and kind of use that as thinking about patient safety. On the other hand, being someone who's been involved in telemedicine, being part of an industry that it is trailblazing, that's all about pushing boundaries and making change, we absolutely want to improve access as long as we can do it safely. So I think there's certainly a balance to be struck there. But at the end of the day, telemedicine is medicine, right? We're in the business of healthcare. It's enabled by technology, but the phrase of move fast and break things, like, I don't know if we can really do that all the time here, right? Because if we break something, that's a patient care, that's a patient life, and we're truly bound by the Hippocratic Oath to do no harm. So I think with that regard, it's okay to be in a really rapidly moving space. I think it's okay to be innovators and to trailblaze, but I think we also need to kind of trust on the wisdom of what really is an ancient profession in medicine, and have a little patience. Take some time to make sure we do it properly. And we definitely know that there are those out there that are having programmatic approaches towards tough issues like controlled substances to make sure that we have the right guardrails in place, to make sure that we develop the right safety nets, the right patient selection. And I think we do all of those things. Absolutely, we will be able to figure this out, but I think patience is definitely warranted to assure that we have the right best practices in place, just given that it's a high-risk situation.
Right. So do you see the reinstatement of these in-person requirements kind of a stepping stone to maybe removing those in-person requirements, or do you feel that there should always be some in-person component when it comes to the prescription of controlled substances?
So my answer is I don't know, right? Because I don't think we have enough data to know if it's safe or not, right? And I think this is where we go back to thinking about telemedicine as medicine. When we put new technologies in place, when we put new pharmaceuticals in place, there are trials. There are safety and efficacy trials that we put out to understand kind of what are the impacts of the decisions we make. And this is a great example of big policy changes that could have very damaging unintended consequences. So I think kind of understanding it, putting best practices in place, defining what the patient selection is, I think absolutely we can do it. We've seen time and time again in telemedicine that we have surprised ourselves on what is possible. But I think the common theme across almost everything we've done in telemedicine has been the program. What are the in-person players? What are the virtual players? What are the goals and objectives of a program, and how do we get there? And I think that very much the same with a topic such as that.
Okay, all right. Switching gears a little bit, interstate licensing and telehealth across state lines is a huge issue. I know that Access TeleCare requires their providers to be licensed where the patient is. And then there's a bunch of telehealth groups pushing for either expedited licensing compacts, state reciprocity agreements, as well as just requiring plain licenses. So could you tell me a little bit about why Access TeleCare likes providers to be licensed in the state where the patient is in?
Absolutely. So standard practice has been for the physicians to be licensed kind of where they are as well as where their patient is. So if we're in the same state, one state license. If we're in different states, then the physician is licensed both where we'd like to say where their feet are located and where the patient's feet are located. And the models of care that we work in are inside of hospitals, very sick patients, critical care, ICU, acute stroke, cardiology, heart failure, arrhythmia management, et cetera. And it's really important that our medical staff, that's part of our organization, is looked at as peers to those who they work with. So having the exact same licensure process, the exact same medical staff privileging process is the exact same approaches towards documentation and order entry and billing, so that they're truly our peers with those who are in person. We think that's really important, so that we're not viewed differently. Time may change, and there may be some innovative approaches towards licensing and reciprocity that kind of change the perception. But I think where we stand today, it's really important to be viewed as a peer to the other physicians and a medical staff. And for that reason, it is super clunky. It's really time consuming, and it's a huge pain that consumes a lot of resources, but it's important to have that peer level type of relationship with those we work with.
Okay, that makes sense. And if I remember correctly, you were talking about liking FSMBs, the Federation of State Medical Boards, expedited licensing compact. So can you tell me a little bit about if some of your physicians have used that and what their experience was?
It's been a positive experience. We're new to it in the last 12 months or so, but strategically is really important towards bringing new providers on board and getting them credentialed. We may have groups of physicians that are covering 5 or so states, and when we recruit them, they may only have one medical license. In some cases, it can take 6-8 months to get medical licenses, and so being able to involve the compact to accelerate their ability. It's not all states, but it definitely has helped us to expedite licensure in the states where the compact does exist. And it's definitely part of our overall licensing strategy and recruiting strategies to involve the compact.
Okay, great. Something I wanted to ask you about that's kind of interstate telehealth adjacent is we're all aware of the provider workforce shortages right now. Especially with nurse shortages in the healthcare system. And I was wondering if you think that telemedicine has a role to play in kind of remedying some of that issue.
So I'll start out and say I think telemedicine is a solution to everything, but I'm completely biased. But I think in this kind of this particular instance, we're an organization that is comprised of prescribers. And nurses, registered nurses are not prescribers, so it's outside of kind of what we do. But I think that time and time again, what we have seen is that virtual models of care are really impactful when scoped appropriately as part of an overall approach towards a role, an objective, a goal. And so important to our organization that we took the word physician and the word telemedicine out of our name. So renamed the organization Access TeleCare last year because we do see the entire model for virtual care being part of the service offering that we're able to deliver with hospitals. So short answer is we absolutely see that. When you think about what staff do in person, a nurse may need to be there to pass meds or administer medication, be there to adjust a drip rate on a continuous infusion, may need to be there to do a dressing change on a post-surgical patient. Those are really important hands-on types of activities or deal with an acute situation. But they're spending a ton of their time in documentation. And they're not bedside, they're documenting. And so the comments earlier around productivity, I think really resonate. And where we can use telemedicine as a way to scale out in-person team members and then augment their work, understanding here's the scope of what needs to be done from a nursing perspective in the care of a patient, and knowing that part of that work is going to be done in person, part of that work is going to be done virtually. We've seen that work really, really well with physicians. We've seen that work really, really well with nurse practitioners and PAs. And so I think as you think about the rest of the care model for those who have to be in person, we believe it will translate well.
Okay, that's great. So switching gears again a little bit, over the last 10 to 15 years, we've seen a large investment in telehealth companies and health tech companies, especially throughout the pandemic. I was wondering if you think that investment is in a bubble right now?
So it's, being part of an organization that's been involved in 4 transactions in the last few years has been an interesting experience to see the kind of the ebb and flow of valuations. I think in terms of telemedicine, we're definitely still kind of writing the book right now on telemedicine. We're defining what excellence looks like. We're gaining understanding around what scales, what's sustainable, how to be profitable and sustain that. We're also seeing a total addressable market kind of continuously expand, and it's redefining itself. So I think from that standpoint, it definitely, I think, continues to be a space where it warrants investor interest, and I think it's well warranted. Our peers in the public markets, though, have definitely, it's been a rough time the last few years, and while that's not fully representative of the entire market, it surely is impacting valuations overall.
Mm-hmm. Okay. And we've seen just tons of mergers between larger medical groups and telehealth startups. Do you think that's something that's going to continue and, we're going to see in the future as the market consolidates?
For sure. I think we definitely anticipate future consolidations as telemedicine evolves.
Okay. So we have a bit of time left, so I'm going to ask you, how will the ending of the PHE impact access telecare?
So the certain models of the PHE, I think, really expand access for patient care. And being well established prior to the PHE, having processes and policies and procedures in place about how we took care of patients, whether those patients were urban or rural, how we handled billing, how we handled supervision. Mm-hmm. We largely did not change those models out of just concern of uncertainty, not knowing what's going to happen in terms of the PHE legislation. I think as we have some clarity about what's ending and what's staying, and then what's maybe still in some temporary, mm-hmm. Where we're seeing, I think, probably a lot of optimism is in patients who are outside of who are within metropolitan statistical areas, so the non-rural populations. It definitely seems like those populations, especially those at home, will have a lot of opportunities to have expanded telemedicine care, and we're super excited about that. The models of care that we've been heavily involved with around rural medicine, those models translate well into patients who are in larger areas who have challenges with access. Mm-hmm. And so from that standpoint, we're very excited about the changes.
And looking towards the future, over the next 10 years or so, how do you see the telehealth landscape evolving?
So I think going back to the topic of programs and scale, and how those programs scale, as well as consolidation. So those coming together is scaled programs that are the result of consolidation, I think really will define the future. The last talk that said, the topic we talked about in 2014, we're talking about the same topic today. And I think in order to not be talking about today in 2023 and the same topic in 2033, it's going to take all of us to be evangelists. I think the hardest thing about telemedicine, for those of us who have been in it, and many of you are, is the change management. Not only are we changing where the provider is, we're changing the care delivery models in an industry that is highly resistant to change. It's exhausting work that's fraught with kind of regulatory issues, and you really have to be highly persistent about forcing that change. But telemedicine is the enabler for kind of all of this optimistic discussion that we had. And I think as you think about all the different parts and pieces of all the companies that are represented here today, as well as our other peer groups, they're all just slices in this larger care continuum. And I think as we see consolidation, as each of those become to be aligned with one another, thinking about programs of care, I think that's where we're really, really excited about the future.
All right, well, thanks so much, Chris. This was great.
Thanks, enjoy the opportunity.